Next one. So this is a 64-year-old lady who was diagnosed with hypertrophic cardiomyopathy with NYHA class 3 symptoms for 5 years ago. And she has now developed severe heart failure in spite of maximum tolerated medications, including right heart failure. Our echo done recently, which I'm going to show you, shows a gradient of 106. And she also has severe mitral regurgitation with systolic anterior motion leaflet. So it's a very complicated case with MR plus HOCM. So next slide. And you can see here, I did a transesophageal echo. And what you can see over here clearly, there's a systolic anterior motion of the anterior leaflet. There's a very turbulent jet across the LVOT. You can see a very thickened interventricular septum, which is bouncing there. And there's also a posteriorly ejected MR jet. Next slide. And this is the transthoracic echo. Just play that. And that's the thickened septum. You can see that the interventricular septum measures about 18 millimeters. And then you can see the gradient over there is about 3 to 4 meters per second. Next slide. We did a coronary angiogram to show the right coronary artery is normal. And we are looking for a good septal perforator. And what you can see here, there's a bit of a problem. The first septal perforator is very small, but the second one is a bit big. And that's probably the only target that we can do. So that's actually what I'm going to focus on. Next slide. I did an invasive hemodynamics, and you can see how impressive it is over here. You can see on the left side the screen, which shows all the characteristics, the spike and dome appearance of the aortic tracing, the Brockenborough phenomena, where we see a post-tectopic decrease in pulse pressure with a spike and dome increase and a significant increase in the gradient. And the same over there, over the left side, on the right side shows you the pullback, that there's gradient is at the level of the LVOT, not at the aortic valve. So with that in mind, I'm going to go into the room now. And now focus on me inside what we've set up. Can you show the cameras now on us? Come, Mike. What we have over here, we have an access to the right arm. You can see that we have right radial artery. We have IJ for a temporary pacemaker wire. So we're going to do radial. I took a GR4 and advanced the catheter into the LV. And if you can you see hemodynamics? Ali, can you show them hemodynamics? And can you see the hemodynamics on the screen? Shows you that there's significant LVOT obstruction with the left ventricular pressure of 250. And I'm actually going to do a pullback tracing, and you'll see now that the LV is going to come down, the pressures will drop. As you see that, it is actually LV has dropped very significantly because that's near the LVOT, and see there's LV pressure. And can you record that, Kristen? It's 119. And then when I pull back into the aorta, there's no gradient between the LVOT as well as the aortic LVOT. Do you see that? In the aortic valve. So the problem is obviously a significant LVOT obstruction. Roxana, I want you to do a baseline quickly, transthoracic echo, while I switch to I will switch to a, give me a CLS, is it 3.5? All right, so let's get a wide wire. So we've given heparin. Our goal is to do an alcohol septal ablation of the first septal perforator. And if the SAM doesn't improve and the MR is continuously severe, then we will consider doing, sometimes it works out, is to do a mitral clip. But today we are going to focus on one part of the procedure, is the alcohol ablation. Now, one of the, as you know, the risks of the alcohol ablation is, can see the echo, by the way? Are they showing echo on screen? Yes. So look at the echo, and you can see over here very nicely, there's a very thickened interventricular septum. And I want you to show what the MR is like, what the grade of MR is. It's not important for me because I can see that. The MR grade doesn't look so bad, but I think the main thing is the LVOT obstruction and the significant gradient there. Can you do a Doppler singlet there? No, across the LVOT. So she's Rosanna's doing an LVOT now. Yes, increase the erasing velocity. Good. Kristen, you made a tracing. Oh, Sophia's gone. So can you go higher scale? Huh? CW, do CW. Do CW. Okay, good. So that's it. You said they showed it. So the CW, look at that gradient. Yeah, do it there. That's the dagger shaped gradient. See that? That's not the MR signal. Let's go more towards the aortic valve so we can show the dagger shaped gradient. And just show me the peak gradient. Go near the aortic valve. Yes, that's good. Put it there. And now do it. Okay, good. Record that. Next to the peak gradient. Measure the peak. And let's do the same thing in 3-chamber view. 33 max. Okay, let's do the LVOT in peak in the 3-chamber view. Because we got a higher one here. Who's that? Okay. Yeah, you see the dagger shaped one over there? And measure the one which is the maximum. I think it's obviously a little more than that. Much. No. The one on the left side more. Yes. Yep, right there. No, lower down there. Yes, at least. So keep going some more tracings. Can a little better? Can you go to a little better tracing? Sana? Yep. Okay. You see that it's covered. It actually goes up to 5 meters almost. Okay. So let's go ahead. Rosanna, we got a good picture, okay? So let me just get a guide in. I'm going to now use a CLS guide catheter to engage the left coronary artery. And if that doesn't engage, I'll use a CLS3 if we have one. But I think that this is good day. The MR, we didn't see the MR grade, right? We forgot to check the MR grade, but it's okay. Let me just keep going. We'll check the MR grade afterwards. It's very important to do echocardiography, and anesthesia just has mild sedation, right? Steve, do you want to talk about the anesthesia that you're giving her to maintain the pressure?
Yeah, I'm just giving some mild sedation.
Mild sedation,
Mild
that's
sedation,
right.
yeah.
And you're avoiding propofol, correct?
Correct, yes.
Yes.
Don't want to vasodilate her too much.
That's right. We did. So I'm using a CLS guiding catheter. I'm going to engage the left. I personally do all my alcohol ablations through the radial artery and not through the groin. And I put the pacing wire through the neck so that because there's about a 5 to 10% chance the patient will require a pacemaker. And so that's why I put through the neck so that the patient can ambulate after the procedure, immediately after. So I'm just going in with the CLS. Can you put this on? Okay. Now let me just get this into the guide. Okay, good.
He is. He's on vacation. Yes.
Okay, put it out. No.
So if we have more of these to do, I guess he would not be.
Okay. Good.
Probably was there slurring in his text message? Not yet.
Okay, Mike, do you want to get this? So Mike is getting everything ready. Okay, good. Can you test here? Test. Okay. Sorry. Good. Good. I'm trying to engage the left. Sometimes it's challenging. It's in the left cusp. Test. Oh, can we just get the wire, please? Not a reasonable size. I'm just getting access now. I'm trying to get access to the guide catheter. No, don't take it out. think this is a possibly. Okay, let's see what there is. I'm just having a little problem engaging the left. Can you test, please? Test, please. Might need a. She can't take a deep breath. Okay, test.
Have her take a deep breath.
Do we have a 3 CLS? We may have to. Yeah, we probably need a 3 CLS. Yeah, let me just try one more attempt. Can't take a deep breath. That's the problem.
Want me to have her? Take a deep
Test. No. Didn't she?
breath? Good try.
No, I think it'll be difficult to get this. Okay.
Trisha, can you take a big deep breath for me?
No, not yet. Not yet. Test. Yeah. Can you get the wire? So we're having a little bit of a problem getting the guide in. Let's take one more try. Putting the guide in. No, it doesn't go in. It's not very difficult to get it. So there's a bit of a challenge in the guide catheter. Okay. Okay, hold it like that. I'm pulling it back, trying to put it at the left cusp, and then trying to go up. And I think the curve is not enough there. All right, so let's just exchange this out. Yep. Akandi, you agree? Should go with the 3-0 guide? Push the wire. You're losing wire. Okay, good. Huh? Okay, good. Ready? The other guide we can have is a 3.4. Yeah. Do you have a 3.5 JL4? No. We can use a CLS3, right? Yeah. Okay. Okay, so let's try a CLS3. That was a 3.5, right?
What I gave you was a 3.5. This is a 3.0, or you want an FL 3.5?
Yeah, I'll try this one first. Let me try first this. Can I try the CLS3? Not yet. No, let me. I'll do it to the. So once we get the guide in, we'll decide what sort of septal perforator we are going to use. So as you can see, I put a temporary wire right side in the RV apex, which is in a nice position. It's going to increase the curve to keep a good curve there. Ma'am, if I ask you to take a deep breath, take it, okay? Okay, good. Flushing forward. Good. Okay. Yeah. Okay, good. Okay. Okay. So I go here and then like that. Okay, good. You can take it out now. Okay, good. Can I test? See? Okay, good. Now take a deep breath. Take a deep breath. Test. Good. Breathe normal. That's good. So we got a nice access into the left coronary system. I think the pressures are okay. So just damping a little bit. Okay. Test, please. Just see the coronary access. Yeah. That looks good, actually. I'm just going to make it more coaxial. Okay, good. And what I'm planning to do is to take one good picture of the septal perforator. There's a bit of damping of pressure, and I can't understand why. Let me just get it back a little bit like this. Okay, good. And this is a small picture I'm just taking of the areocranial. And you can see there's a very small first septal perforator, which is very tiny. And the second one is bigger. So can you see that? So I'm going to try to see if I can get into the first one. And if I can get into the first one, I'll take it. If not, I'll go through. So get me a 2mm balloon. Yes. And get me a BMW wire. Do you see that, Akanti? Andre, can you hear me? You want to scrub? I would like to go through the very first one, which is very small, though. Can you get the over the web? But I doubt whether I can get it. Yeah. Okay. Can you get me the balloon? 2 more?
Yeah, I got it here.
Okay. And if I can't get it, I'm going to go to this next one. It's okay. I'll probably try to do this first. Okay. You want to put the balloon in?
I'll put it on now.
Yep. These are sometimes challenging to do. Yeah, go ahead.
Oh,
No, go for backload it. Backload. Yeah.
just making sure they introduce.
Yeah, I got them. Okay. Good. Pull the wire back. Okay. Good. Pull the balloon back. Pull the wire back. Yeah. No.
Go back a little further.
Okay. Yeah. Okay. Pull it back. Good. Pull back more. Good. So we got an over the wire 2mm balloon, and I've taken a BMW with an extra curve, and then I'm just going to go in. And if we can't get it with this, I might try a whisper wire. And I'm going to see whether I can get the first or the second perforator. I'm not sure which one I can get. Okay, good. Test, please. Test, please. So I'm in the one of the perforators now, right? Test, please. Yeah. Where is the guide? Okay, good. So we're going in like this. Can we just test? Can I see where we are? Yes, I'm trying to go to one of them. I'm going to try first through this wire. Test. You see, it goes into, okay, so it's going in, no, that's in the LED. Okay, good. Yeah, this is the LED. Okay, good. All right. I don't need a bookmark. No, it's okay. I mean, give me a test. Okay, let's get the guide inside better. Test now.
Test that.
It's in the LED. Okay. Test. No. Okay. No, I'm trying to actually go into the first septal perforator. So just stay like that. The first septal perforator is much more in the early part here. Okay. Now give one injection, hard injection. Okay. See, but I think that one is too small. You see, you agree with that? I think, yeah. I think we should go for the second one.
I like the second one because it bifurcates too.
Yeah, but I'm saying that I think we had a better chance to get into this. Yeah. So we need to just to increase the curve of the wire. Okay, good. All right. Give me the. Can I have the lights a little bit? I just want to see it. Yeah, see, it lost its curve. And usually you need to give a second curve to help you go into the septal. So, yeah, it'll be okay. So I'm trying to, this is Dr. Akanti, by the way. Akanti just joined me. He said, I don't know how to do this procedure, so he wants to help me out. Okay, so Roxana, once I get the cross, and then we'll go for the alcohol. Okay, good. Test, please. You think so? We're almost there. See there? And hooking it is so difficult sometimes. Oh, it doesn't catch. Hate that, right? We can pull it away. You think we should use a different wire?
So can we get a run through?
Yeah, I think run through is good wire.
Can we get a run through?
Yeah. Okay, can I just can I see where we are? No. That's what I did last time, right? No, no.
You don't need to. The run-throughs are usually good.
If not, we'll get a whisper. Let me see what the problem is with this curve. Okay, sure to give the curve. Okay. No, don't make it too far away. Make it hook. Okay, let me see. Your first wire is to hook it. So we're doing what is known as a double curve on a wire in order to get it. Okay, so you have to do this, otherwise it doesn't slip inside. Come, you want to do it? Try. Go ahead. You need a torque or you can do without it. Okay. No. Okay, so good. All right. So we're going to try to. Oh, you gave us short wire. Okay.
Do you have
All
a
right.
dock for this?
Oh. Okay, we don't need a dock. Okay. No, it's, no, it's going away. No, it's not there. Test. No, it's got a very bad angle. I'm wondering whether if we advance this balloon will be help you to get a curve. Hmm. No. Test here. Test here. Sorry. Test. Let's try to go far away from here, and you could try to do this. Okay, good. Good. Yeah. Advance. Good. Test. No, it just came out. No, see, it's not there. Yeah, why don't we change the curve? Let me just take one more try, and we change the curve of the wire. Can I get a whisper too? Yeah, it just slips out, right? Let's try one chance of hooking this wire. It's straightened out a little bit, right? Not yet. It's a smaller vessel, right? So maybe we should. And this is a much better wire, as you. I agree with you. We're trying to hook this.
If this doesn't work, put this down the LED and we'll take the double wire.
Okay. All right, so let's go there. I may need a torquer now. I usually don't use a torquer, but I
think a torquer is a good idea.
No, they have sometimes. I'll tell you what they do have. You have a steerable catheter inside. Okay. No. They have a hooking and not hooking. Just here. Right? Goes on the diagonal. I'm just thinking if we don't have the right plane. What do you want me to do? LAO. Okay. Just here. No, I don't think we'll see it better here. Really. AP straight AP is not usually the way to go,
No,
but
it is. I agree with you. Higher up.
yeah, I think it's higher up. Yeah, it's somewhere higher up that we're missing it.
Open that whisper.
Okay. One side. Test here. Test here. I think I'm the second septal preferred. Let's go the second, the one I don't want. Right? Now see here where we are? This is what I don't want. That's it. Yeah, it's just almost there we got it. Right? Let me see what can be made. So we're now trying a whisper wire and hoping that we can get through with the whisper wire. It's coming. It's sometimes happens. It usually goes in very easily, but then once in a while you can have a case where you just can't get into the perforator. I just wonder whether our curve is too big. Yeah.
Think?
Yeah. Yeah. So somewhere here, right? You want to try? Good. Good. It's there. Creatinine's okay, right? Yeah. Good. No, you're far away. Can you call Vishwa once? Just text Vishwa. Yeah, yeah. Just text him. Call. Text him one. He wanted to be in the case anyway. Yeah, so just tell him Saibal is doing the alcohol ablation. Okay, good. Very good. Looks a challenging thing. Spin it. Test it. Looks very promising. Good. Vishwa, yeah, Vishwa. Can you come here to the alcohol ablation?
Sure, sure. Which lab?
Room.
Lab one?
Yeah. Okay, so let's give 4,000 of heparin. Go to 7.5 frames per second. I'm sure it is. That's what we're just imagining. But the problem is, this is the only good plane to see it. Okay, let me try another plane. Let me just see another view to get it, or just another view. Thinking with we can see some stuff. See, the problem is you have to do cranial to get the. It is there. And actually, you're right. It's probably coming off some higher up, and we are just.
Yeah, freeze that. Oh, that was a good shot, actually.
Not catching. I see if I catch it on the other side. It should catch even the diagonals. It doesn't catch the. The only other option is to make a little sharper bend. Right? The first bend. Yeah, that's what. Can I get the introducer?
Lower that for me.
See, it looks like it's
So
coming.
look where that diag's coming off.
Yeah. I made it almost a 90-degree bend. Can I get this thing? Yeah. No, actually went in. See, the first septal perfida is initially what I wanted. But the first septal perfida is too tiny. That's the correct branch. It's actually very small. And I can try that. Doesn't even hook. Interestingly, when you don't want it to hook, it hooks, right? Here it doesn't go here. Huh?
That's the spot. That's the spot.
I can't get it in. It's somewhere here. How would that help?
It won't.
It'll help only if I didn't have instability of the guide catheter. The guide is very stable, right? No, I've never managed to not do it.
Do you want to use a fielder FC?
Yeah.
Or okay.
Whisper is much whisper.
Good. No, Whisper's good.
No, I'm not going to the septal at all.
Second septal you went into.
Just once. I mean, that's
Do we have like a fielder?
it just goes everywhere but the branches. No, I don't. Just try fielder XT
Yeah. Do we have a fielder XT?
or fielder.
Yeah.
No, it doesn't go in.
Acting like a CTO.
It's just I can't get a hook. You know, I don't know whether the curve I did is too big or too small. Just for the sake of it, right? Yeah, do that. I agree with you. But you need it to bend downwards into this vessel. Usually you need two bends. Where are we now? No, I'm way fast. Okay. So just scrub. So which way? He doesn't have a good first septal, but the only good one is a second septal perforator. So I'm thinking of going to the second septal perforator because the first is very small. That's the only one which is good. I'm finding it very difficult to. What do you want? What sort of wire do you want, Vishwa? We have a whisper here. I tried a BMW.
We tried everything.
Hmm. Yeah, play with the whisper. That's not the whisper. Is that a whisper? Yeah, give him the whisper. Yeah, get the whisper. Where's the whisper wire? Let's make your curve. You want to. You want to do a single curve? I usually do double curves so that hooks. You have to hook it. You see, it won't go. It's too small a curve. You have to make a bigger curve too. Yeah. All right, Vishwa, why don't you try? Yeah. It's a small vessel, so. And the gradient is. Hmm? It's a very small vessel, yeah. And the problem is, the first one is very, very tiny, right? Mm-hmm. Mm-hmm. Mm. No, if you can get it, great, take it. Spin it there. Spin there. Let me see. No, it's not this one. Yeah. You want torquer? Yeah, you torquer. Yeah. No, second. That's the second. That's correct. No, it's a very. That's the first one. I don't know. If it is,
No,
it'll
it's
be.
the first one. It's the main branch.
But it's not going anywhere.
Yeah. It's not as big as the second one.
Okay, let me see if that goes. See, I just it's in the okay. Mm-hmm.
That's the first one that, remember, that's the one where it first went into the straight one. We want
Actually, we want to go into down if you can get into that.
the next one, the bigger second.
That
Back to the
bifurcates.
LED.
That's actually quite good. Let me see. No,
Oh,
no, this one I went into. For some reason, it's something weird.
so that is
No, this is LED. Okay. Yeah,
directed into it.
yeah, but it doesn't go.
It doesn't go.
Yeah, yeah. It never hooks. No, LED.
That means it's slightly in a different plane. Now
That's what I'm
it
thinking.
straightens up.
Yeah.
Okay, let's take a picture here.
I think we're obviously not in the right plane.
Yeah.
See, that's the one I want to go for. See that? That's the biggest one.
That's the biggest one. And that's
I mean, otherwise, if we had gone for the first one where you went through, that's a small profit. That's also good, but we can't go there. It's a very tiny vessel. I think you should take this one, or if you got the first one going right down.
we'll get into it.
Now you're further away. You're too far. You're too down.
Is it into the
Yeah, yeah, this is okay. Yeah, no, we can't go there.
okay.
So let's come back.
Okay. Now that
I would pull the balloon a little bit back. Yeah. This is where it doesn't go in. Hmm.
it's all the right moves and then
Yeah, it slips out. Yeah. I just wondering whether I make an increase. Huh?
give me a picture here.
Yeah, it's
Are
the
we
same.
distal to it or no? Okay, so we're at the right spot.
No, I think we're distal to. I think it's coming off something higher up. We're making some sort of. We are assuming that it's like this.
Yeah,
We're not in the right plane. That's it. Can think of anything else. Okay, give me one more.
okay, so let's put a sharper pen here. Now that we are
Yeah,
our wire is closed.
and get the light on.
Turn the lights on.
So we're doing all sorts of permutations and combinations of wires. See, that first septal perforator is actually what I would have loved to do, but that's very tiny, and you never got into the big branch. And if we get that, I'll take it. With the one that going this way, I don't think we got into the. Okay, I mean, if you.
The one that it's the bigger branch actually runs at
But then that's not a good branch to go to, right?
going to upload both.
I would pull the balloon back a little bit. Huh?
Let's start from here.
Somehow not in the plane, because if you push, it's not. It's just slipping out. So it looks, it appears as though it's that, but it's not that. Hmm.
Have anything with a side port here?
No, there's a catheter called Venture catheter. You remember the?
Yeah.
I wonder whether it's available. No, it's the same issue, right?
Yeah.
I wonder whether we.
Correction, but
I think it's there, but it's not there.
It's not
Maybe-
there. I have a. Give me one run through where.
Try like the opposite of that. Even though it's pointing towards
Yeah,
there,
just
it's
one.
there. It's either
Or just look
crossed
at make it
out
look
down,
upwards and see
or
if
I
it
think
goes.
it's somewhere else. What's
there
that?
you go. Yeah,
Yeah, yeah.
That looks
Okay, that's good. Cindy, Cindy. Yep, we got it. Very good. Okay, so let's spin that down there. No, any whichever launcher is, I would come back a little bit, Vishwa, and then turn it to the other one. Yeah. Yeah, yeah. Advance the balloon back inside. Good, awesome. Now I can pull it back. Yes. Yeah. Okay. Let me just take a small picture because I just want to see. Good. That's good actually. No, no. Spin it, spin it, spin, spin it because you want to see it not buckling like that into a branch. Okay, good. That's very good. Cindy. Okay, so we need to advance. Actually, you know what? The more I think about it, is going. I go a little bit more in. Okay, stop there. Stop there. Okay, good. So let me see whether we are in position.
I think we're in very good.
Okay, good. Now let's inflate the balloon. So we're going to inflate the balloon now to
You're ready to
six.
inject
Yeah,
and
yeah.
it'll fill.
Yes, good.
Maybe
No, it's okay. It doesn't matter.
it'll at
So,
least fill only
well,
the
yeah.
one.
Well, I wanted to fill. I wanted to go alcohol to this side. Okay, that's good.
Both of them.
Yeah, floor.
Do you want to do the main branch?
No, the baseline. Yeah, because that's where the muscle is. Yeah, go up till 6. It might be. I'll show you the 6. Go up 6. 8. 8. Okay.
Let's
You're
take
holding.
yeah, if our balloon is still a little bit in the.
Okay, so this is very nice position. All right, so stay at 8. Okay, now
We should actually
give me dilute contrast.
if we pull the balloon back a little.
I don't want to put it. You don't want to take the risk. I mean, I can actually, if you want, I
back gently. What it would do is inject
okay.
into both the branches.
Yes. Okay, just pull it back a little bit. Stop there. I would pull back a tiny bit. Yeah, good. Okay.
Good.
Okay, 50-50. No, in a 3 cc syringe. Yeah, give me a 3 cc syringe, please. So we like to inject alcohol in a 3 cc syringe. No, not yet. Yes, in a 3 cc.
Need to inject into it.
Yeah. Okay. So let me give that. So you ready? I like. So the first thing is just to give a teaching point.
The balloon.
Floor.
Give the orientation and pull the balloon back.
Floor.
And that curve, it allowed the
Floor.
curve. And then it went in.
Okay. So it dive down. You know that, right? You can come back a little bit if you want to, right? Let me see. Okay. Okay. Let's come back a little bit.
Come back. The breast
No, you have a very good guide. Okay. All right.
This slips in. That's what
It does slip. If it slips in, then don't leave it like that.
yeah, we're not going to do anything.
Okay, so we're going to 8 atmosphere.
Yeah, see, it slipped.
It slipped in. Okay,
That's
7,
okay.
7, 8.
I think this is good.
Okay,
But this,
good.
This gives
That's
us
fine.
the limit of where we need to be.
All right, so I'm just cutting out
I
the
think
wire.
it's going to be okay.
Let me just that. So what we're going to do is we're going to get some alcohol to make sure it doesn't spill into anything else. So give me some light here, regular light.
So that's diluted contrast.
Yep, I know that. Yeah, keep it up at 8. Okay, good. Fluoro. And let's get city, yes. Okay, so it's only going to this other branch.
Yes, you are.
I would prefer the other branch.
Okay. Then put the wire.
Let's put the deflated.
Other option is
Yeah.
that we inject, but we don't want to do it. After injecting, we don't want to
No,
do
no,
positioning,
no,
right?
no, no.
Okay, so let's advance. Give us the bill. Give us a BMW wire now. Don't give the whisper.
Okay, okay. Can I have a BMW wire or run throughs that you guys safer actually?
You want a new one?
Yeah, give me a new one. Okay, so we're gonna pull back.
If it's okay, this should be fine. This is.
Let me see the wire tip. Yeah, this is actually good. Okay, okay, good. All right. Let me just deflate the balloon. Okay. Actually, we should go into the one we originally went to. Okay, good. Deflated the balloon?
Yeah.
But maybe a good thing for future is put a wire in the main LED. It gives
Oh,
very
yeah,
good idea.
yeah, yeah. That's what I did last. Okay, so now can you pull it back to me?
Yeah.
Just give me a small test. Okay,
There
got
is.
it.
And you know what? Why don't we, because we crossed it here, why don't we inflate the balloon right here rather than go forward?
Okay. No, no, it came back, did it? No, to me. No, no, no. I need to get the okay, just do it like that.
Good, inflate the balloon here. Because remember, we were able to select the other branch.
Okay, yeah, good.
Yeah, this is good. Go to maybe 10.
No, but then I won't inject one. No, this is too much inside. No, pull it, deflate.
If you go to 10, it'll.
No, it moved up. So can you go down a little bit?
I did.
You advanced it?
Balloon's down.
No, advance the balloon.
I advanced the balloon.
Okay, guides come out. So advance your guidance. Okay.
Tell me when you want the balloon.
No, no, let the guide. No, test. Yeah, now test. I like that position, Floro. It may be, like, I mean, we may be outside, but I'm not sure. I would like to.
Inflate it here and see what it does. Okay, I advanced it a little.
Okay, you did?
Yeah. Go up.
Let me see. Okay, I like that.
This is good. This is good. Position. Go up slowly, very slowly, so it doesn't push it in.
If it does, it's okay.
That's 1, 2.
It's okay. Yeah. It's going the same one.
That's good.
Very good. Yeah, that's okay. I like that. Just keep it like that. All right. 8. All right. Yep. Now let me give. Now I'm just going to give some dilute contrast. This lady doesn't have big spectral perforators. Test. Sunny. No, no, no. Okay, we're in the right one, right?
Exactly feeling the lower one.
Yes. So this is where we want to be.
This is a good.
It's good, sir. Okay, ready for alcohol? Give me 3 cc of alcohol now. So what we're going to do is that we're going to focus on the EKG, and we're going to look for widening of the QRS as we give the alcohol. Okay, give me the alcohol. Yep. I mean, I can give 2.5 is fine for me. Give me 3. No, no, I fill the syringe and I only give.
Syringe, but amount
Yeah,
given is
yeah. Only go 1 cc, right? So what we do is, let me explain that to you, accounting. So we go up to 2.5 cc, and then I'm just going to make sure that it's actually a little bit more. So I know that I'm now 2.5 cc, and I'm getting the air in. Ma'am, you're going to get some chest pain. All right. So you see the pressures are going up, which is a good sign. Yep, hemo's on the top. See that? All right. So I'm going to go start, and I'm going to watch EKG.
About 0.2 cc's is going to stay in the septal line.
Yeah, that's okay.
So,
Yeah. So we wait for a couple of seconds, and this just 0.1 cc I gave.
it's just
Yes, Phil. And you already see VPCs, which is already a bad sign. Okay. So I'm
yes,
just,
because there is good distending the.
and you
Hey,
always
how are
check.
you? Boscanian. Hey, you're losing your hearing, man.
How do we get the lights off the room?
Oh, here.
The
The
light.
last one.
I want the lights on.
Yeah, the last one. That's it. One time. Hit it.
Okay, good.
No, you turned it on now. You want
Yeah, I want the room on. Okay, so the LED is open.
Yep.
So we always want to do that. Now I'm going to check another 0.1 cc. Okay, good. And everyone's looking at this thing, and you can see a couple of VPCs. Ma'am, just be careful. Don't move. Okay. You developed heart block, right?
Not yet.
There was something. Okay.
That was just PVC.
Can you get the heart rate to? Yeah, that's good. PVCs.
Big Boscanian bird. He doesn't like that.
Okay, I'm just going to give a little bit more. Good. And actually, you see that the blood pressure is fine, right? So it's 134. We started at a lower one, and it was not spike and domes.
What's on your ear? Oh, that's the. Are we live?
Yes.
Okay.
Okay.
Just make you look terrible, Steve.
Steve is such an awesome anesthesiologist. Oh my God. We are blessed.
Okay. So like 0.1 cc. The issue with her is that usually when you do second septal perforators, they don't get as much as a gradient improvement as when you do first. But she doesn't have a good first.
So we were able to get into the first as well. So if you want, we could.
We can try there. Yeah, sure.
And give a little.
Absolutely. So we can do that. So
There as well.
I'm just going to give a little bit more of alcohol. So I'm going very alcoholic, and you can see there's some ST segment changes in lead 3, but the QRS has remained constant, and the PR interval is going constant. And you want to develop a bundle branch block. And once you develop a bundle branch block, then that's usually a very good sign.
Also, I would think still in the septum, like we are here.
Yeah.
The bundle branch block may not develop as.
Yeah, but then that's not good.
Yeah.
You the more proximal you are,
That's right.
then that's
that's
right. Yes. But do you see the aortic pressure going up? So when the aortic pressure goes up, that's usually a good sign. See that? It's going up from, instead of going down, it's actually going up. So obviously the LVOT obstruction is minimizing. So, and the beauty is that just sitting, we're doing nothing. We're just waiting, and you can see these changes taking place. And look at the QRS ST segments are down there. So I'm just going to give a little bit more alcohol, and I'll wait again. The LVOT gradient was over 200 gradient difference. It was very significant. And you can see there's no spike and dome appearance. You see that?
Salvage that magic wire that we use. I think we should ablate the first septal as well.
Well, we'll do a gradient. We can just look at it. We can just do this, okay, and see what the septal's done. So, and if we can get the first septal, that'll be even better. So that's done. Let me go. I'm just going to give a little bit more. We've given 2.5. We only given literally, I think 1 cc, which is, I started at 2.5, a little less than 2.5. Yeah.
cc's gone into the septum.
Yeah. So I'm doing very careful, and you see there's no changes in the EKG at all, excepting some EKG on the top.
So that is lead 1. That is showing some ST depression. This V lead may be close to. Is this close to V1? That lead, like close to V1. goes to V1, then we might not see those changes.
Okay, I'm just planning to give only 0.1 cc more, and then I'm going to stop. And then we're going to take this balloon
We
out.
should at least take a look at what it does to, because the pressure has changed. So I think there is some hemodynamic
Yeah, of
difference
course, yes,
already.
yeah. And we'd like a look at echo also. Rosanna? Rosanna, where's Rosanna?
Let's save the rest.
Yeah, you see, she gets the topics very much. Yeah, good.
I have a feeling
Yeah, okay,
that
good.
we should put the other half a cc in the proximal one.
Yeah.
And that may give you the bundle branch block that you're looking for.
Okay, so I think there's no arrhythmic changes, which is really good. Rosanna, you can do. And you know, like basically you do like this, you keep it marinating. Basically, it's almost like it's marinating, so it's fine. And if you can see the bright spot of the echo, and you can see the bright spot is not exactly where I want it to be, right in the base of the septum. And you want it,
Septum. I think that we would get if we go to the first septum.
yeah. So there's still a lot of gradient. It's 23, so not as bad, but still. All right, so I think if most people agree that I think I should. Can you see the LV 3-chamber view? Because usually it becomes bright,
Yeah.
and I think it is a bit bright.
I think that's the area that's bright.
Yeah, which is not what you want. What you want, don't want. Yeah, he gives into ectopics. Yeah, yeah, we're done here.
That's just the pressure that causes a little irritation of
All right, so I'm going to stop here if everyone agrees. And I'm going to deflate slowly. There was a PVC.
Should we disconnect the?
So, yeah, we can disconnect it.
And put it back and then
Yep.
still take it.
Disconnect and put it in. Where's the alcohol?
This is alcohol, Jose. No, we need. All right.
Fluoro ones, just fluoro.
Oh, here.
I need to see fluoro just to see the LED open.
Hey, can we?
Okay, is it beautiful?
Sorry, and it looks.
That's okay. And now we can slowly. Yeah, I saw it.
How about we bring the II down?
Can we just bring down the balloon?
You're also supposed to watch the radiation, Mike.
Yes, sir.
Okay, I'm deflating the balloons very slowly, and I'm going to pull it out, and I'm just going to take this out and throw this balloon away. So take this balloon, just disconnect it, and throw it away. You don't want it to be anywhere close by. So, yeah. So now we're going to make.
Fresh balloon with a fresh.
Well, let's just do an angiogram.
Fresh balloon and a fresh.
So we can see very nice.
Vessel looks nicely occluded.
So the septal porphyria is occluded. Right. So the first says clearly the S2 is gone, and we are left to see that. I think if we can manage to get into that, if we can get into that, that will actually be very good. So I would actually go for that before we do hemodynamics.
Okay. Let's take.
Let's take a 1.5. I don't think it's a 2 balloon. So let's get a 1.5 balloon. Let's take a whisper wire. Hmm?
1.5 would.
No, same thing. The lumen's okay. Yeah.
I mean, I hope it doesn't reflux.
It's very small balloon. Huh?
Because if we damage
Same whisper.
If we damage the vessel, it's not a big deal. But if it kind of refluxes that.
The tube is. I mean, I don't know. This looks very tiny. I mean, your guide cath is
1.5
too.
is fine.
What is this? Is this the
We can go
contrast?
higher.
I threw the alcohol. That's alcohol. That's contrast.
Over
The wire, yeah.
wire with a new BMW guide wire. To get into that if we can.
Yeah.
that is 2O,
Yeah, that's 2O.
but the OD is not 2O. ID is 2O. These guides,
Yeah, that's true.
no,
Yeah.
the sheath, the ID is 2O. But
Yes,
for the guide catheters, the OD is 2O.
is 2O. All right, so let's get this. So what we are doing now is we are getting, let's see if you want, do you want to change the curve a little bit? I think I would increase the curve a little bit. Can I get a, no, it's there, it's there. But I don't think we'll be able to get into this perforator with,
Yeah, let's just get into the LED. That was my goal. And then we'll
yeah. Oh. Okay, let's go. Keep going. So we've done this for second perforator quite nicely. We haven't affected any hemodynamics at all. I mean, sorry, EKG changes. We are going to check hemodynamics later. The LVOT gradient by echo is about 22. Okay. I don't see it. Just me where I am. No. One of them is done. We're trying to do the other one too. Okay, good. That's in the LED. Do you have any chest pain? Okay, this looks like good, huh? Want to see it?
looks like it's directed into it.
Yeah, it's in a good position. I'll tell you what we should do. Let's get the whisper there and let's go with the whisper because this will not navigate it down. Okay. Okay.
Let's take this out. This part doesn't have the, its end is return.
It fell on the ground, huh?
Okay, then.
Fell on the ground.
Put a daughter on this mic.
See, I think we need to.
That's our friend.
I doubt it. Well, actually, this does look promising. Yeah, no.
Slide, go down.
That's fine. Are we? Let me see. Sini? Okay, so we're in a weird branch. You see the branch?
Yes.
So I wish we can. I'll tell you what. We can advance the balloon.
Which one do you want to come to?
Out of the bed. Yeah, this one, of course.
That.
No, this one. Straight down. I would actually come back with. I would go perpendicular, of course. No, we don't want that. Now it may be very tiny and maybe it's okay. That looks promising. I would advance the balloon first, not lose it next time because we don't want to lose it. No, that's in a second. No. No, 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 that's the septal, second septal. No, no, it is, it is. I know. No, no. Oh, LED, yeah, yeah, yeah. It's become very tiny. It may not work. Okay.
Yeah,
Let's just take one picture. Let's see where we are. Just stay there. Ready? Okay, stay there. Stay there. No, I don't think we are in. It looks like we are in, but it's actually somewhere.
it's
It's
in, but it's not. It's bifurcation where they.
well, the EKG had the right one has changed in lead one, which is a good sign. I would take this. Beautiful. Actually, this is really nice. Perfect. Okay. So let's advance the balloon. 1 minute. Let me just before you do that. Let me just.
The wire is the
Okay. Good. Good. Okay. Not yet. The dot is a single dot.
Yeah.
Go a little bit more.
Balloon is in it now.
Fluoro. Just fluoro. No, go a little bit more.
Then
Okay.
very little.
No, go. That's okay. Go a little bit more.
This is how big is how long is this balloon?
It's only 8 millimeters. Okay. Good.
Take a cine.
I wouldn't guess any. Okay. So let's
We
try.
are good now.
Let's try this. But remember, this balloon sticks out into the. Okay. Let's go.
It sticks out into the LED,
Yeah.
but the bulk of the balloon, including the center, is clearly
Okay.
in the.
Okay. Go to 7. I don't want to pull. I hope it's not sticking out. It looks okay. Go 8. Yeah. I just hope that we have occluded. There is a Cine. Yeah, yeah, Cine. No, yes, it's okay. Cine.
Okay.
Okay, so you are a little bit inside, but the LED, but I think it'll be okay,
Yeah.
right?
It's occluded. Yes.
All right, so let's get the contrast to 3cc contrast. The dilute contrast. So we're going to do dilute contrast and see if we can get it in. So I'm pulling the wire out. Guys, can you guys hear me as Cine? Cine? Okay, good. So you saw that? Alcohol went through. All right, so now let's get me this thing, alcohol. Sorry. Give me that whatever left of alcohol. And now we will probably inject the rest, which is. Now, can you get the lights on? Okay, and now we're going to inject a little alcohol in, and let's keep pressure on. And can we do an LED injection, please? Can someone do an LED injection, please? Test. Test. Okay, good. See, I wonder whether the balloon should have gone more distal.
I think there is. Yeah, clearly balloon is clearly occlusive.
No, but it's a bit of the shoulder. The balloon is in the LED.
The proximal shoulder, but
Yeah.
the bulk of the balloon is in the.
Okay. Yeah.
Okay, let's do it.
So we're going to go very gentle. Injected 0.1 cc again.
Right.
Yeah. Can I give contrast to the LED and see if the LED is okay? Good. You see, yeah, you see the balloon is in the shaft, and I don't like that.
Yeah, well, that's the center marker, and center marker is deep into the septal.
It should
It's
be
not
okay.
very long septal, so that's why you're getting.
Okay.
How much did we inject?
Very little. So now I'm going to inject some. Yeah. Okay. Balloons up. Good.
Yeah.
The balloons, how much is it? 8? Good. Good.
8.5, yeah.
Good. Minimal EKG changes. We were 30 seconds more. All right, guys, can you hear us? We're going to be over soon. When everything's okay? Transmission? Yes. So we're going as slow and steady, and we should be over in about 5-10 minutes.
If you see the balloon, the proximal half is inflated. The distal half seems like it's not filling. I think that's because it's
So
such a
small.
small vessel that there's not much contrast in there. And
Okay, I gave some more alcohol. So we're going to we're planning to inject 1 cc of alcohol in this. And you notice we're going very slowly. There's no rush. Roxana, can you want to show us the echo?
learning thing here is the pace at which the alcohol is to be injected, right?
Yeah.
Saibal,
You have to do
slow.
slow. There's no rush. The more you rush, the more dangerous things can happen. And so I'm going to look at echo, and she's going to show me where there's any increase in brightness. And you notice I'm not giving any alcohol right now, as I'm just waiting. See, the balloon is up. Okay. We also, the key is to have a good anesthesiologist too. Sometimes we don't get that. Now, look, do you see this? Do you see how bright it is now?
Now see that?
How bright it is?
The
That's
outflow tract is now bright.
really bright. So we actually got the first septal preferred. That's really nice.
Remember, last time
We got this.
brightness was down
Yes.
there. Now we have
Now we have
right
it. It's
below
very
the OD.
yes,
That's
which is
beautiful.
really nice. And this is actually fantastic, guys. Can you see that? It'll be really nice to show this, how bright that spot is. I'm just going to give another cc of alcohol.
I wonder what this is related to. I guess the alcohol has a different echo reflection.
Yes, right. Very nice. And you can see the bright spot. Can you do the LBOT gradient? And this is really what I wanted to do in the beginning. I think this is, I give credit to Vishwa. You got the septal perforator. Your skills are better than mine, Vishwa.
Some. Not. So it's that's why we complement each other.
Maybe I should start fellowship all over again.
Well, we have a fellowship coming, remember?
Maybe I could just apply for it. All right, so this is great. I think it's good. Mike, that's the heart, Mike.
I would have trouble dealing with you as a fellow now, Saibal, so I think you're way past that point.
Yeah. Do you also see very nice? There's no SAM. You see these beautiful images that she's showing. There's no systolic anterior motion of the leaflet.
Yeah.
She had systolic severe SAM before. Now, do you want to do color in the mitral valve? And the MR is only mild. There's some turbulence on the gradient, and okay, good. Now we're going to third. Do you want to go third? This thing now? Can you go to L3 chamber view, please?
Just from the density of the outflow tract part of
Yes.
the septum tells me that this
Yes,
likely
is the
would
right
give us
spot.
benefit. This is the
And
right
this is a good teaching case to show that the first, second septal was did, but the real thing is to get the first septal perforator,
Yeah.
and even though it was so small.
Yeah.
And to get this, now you can see the SAM is much less. There is some SAM, but it's some large. Do you want to, you can see the leaflet is being pulled in, but the bright spot, and then what happens over time, it actually gets better over time. So I'm just going to give a little bit more alcohol. Okay, good. Same, the gradient is the same, right? I think that's okay.
some gradient. I don't know whether
But I really like the fact that we got this perforator. You see that, Kathy? How that is becoming bright? And this will shrink. In 6 months, it'll get shrink, and then it becomes even better. So I'm just giving this very,
the second septal will reduce the overall mass of the
yes, of course.
intermediate septum.
Okay, I think we should stop. There's a VPC. Let me see fluoroscopically. I hope the,
Let's stick with our goal of giving
okay, that's great.
1 cc. That's what we
I wanted to
decided
give 1
would
cc. I haven't given yet. I just want to give one more.
1 cc and then call it a day.
Stop. And we could call it a day. So, guys, we're going in the time. We absolutely timed our case correctly. This was a complex case. This is not easy to do sometimes. And you can see getting the first, second septal, and then getting the first septal is doing the right thing for the patient is the right thing. And you noticed we have been patient about injecting. There's no change in PR interval, right? There's no bundle branch block.
Lead 1, the ST segment depression is now more pronounced.
Yeah, which is good. I mean, this is obviously going to some ischemia, right?
Yeah, true.
Is the balloon up? Yep.
Yes, still up.
Okay, good. You having chest pain? I think she's having chest pain.
Oscar.
Okay. I think we should stop here. So you're getting, oh, that's good. Bundle. That's good. Got it. Okay.
Right bundle branch block.
No, left bundle
It's
actually.
a left bundle now.
Okay, so I think we stopped over here. So I'm just going to bring it back. I'm going to take the balloon out.
So traditionally, with the first septal occlusion, we get right bundle.
Yes. Is it?
And septal myectomy, the surgeons get a left bundle.
Yeah, that's true. So this is not,
And,
all right. So you want to deflate the balloon slowly, Vishwa?
we disconnected the alcohol.
Yes. Okay.
Okay, we're coming down gently.
Yes. Yeah, we're going to do an angiogram right now to see it. And that's it.
I think this achieves.
We've actually achieved both. Now let's look at the angiogram and we'll see that both the septal perforators have gone and the LED is patent. Now what this, sorry, Cine is working?
Yeah, the middle part is
Cine, ready? You can see there, the second septal perforator is definitely gone. The first septal perforator, the side horizontal branch is patent, but the branch which is in the septum is gone. And so we're done over here. We haven't damaged the aorta. And now what we're going to do is we're going to show any changes in hemodynamics by, yes, she's gone back to normal, which is okay. And now let's go back to getting a J wire, and we're going to advance the catheter and get some pressure gradients. Can you bring me that? So we're going to go back, and this will be, can you give us about a couple of minutes more? Guys, can you give us some time? Yeah. Yeah. Yes. So we'll in 6 minutes we're going to show you the EKG has actually normalized now very nicely, but we are going to show pressures. So we're going to take this catheter out. Get me a GR4. Yeah.
You want to go with the double lumen catheter?
I was going to cross it with, if you can cross with a double lumen, that'd be great. Okay. Get across it, yeah. Okay. So we are going to just take the final hemodynamics, and that's what your question. Also, answer to the question to the audience, they said, How do we know that we have done the right perforator? I don't know whether people saw the echo imaging. It showed a very bright proximal septum, which means we actually ablated the right part of the septum. That is called
Part that we did not sign that we did not
yes.
see when we
When
were
they said
doing the septal
second, and that's called myocardial contrast imaging. And all you need is a good transthoracic echo. You don't need TE. It actually doesn't help. And now what I'm going to do is I'm just objectively going to show the hemodynamics. I don't know if people saw there was a huge pressure gradient at rest. And now I'm just going in and I'm just going to try to, can you decrease the mag? Let's see, that goes there.
It is just bring the eye.
I'm just trying to go in the right way. Oh. It's not turning.
The tip is very soft, so advance the wire a little more so
Yeah.
that it's not like you will cross.
I'm just trying to get a little. Okay, that looks good.
Yeah, that's a good loop.
That's a good loop. I'm straightening it out and I'm just hoping to pop in. Didn't pop in. Okay, let's see if this goes in. You want to try? Yep. This is a double lumen Langston catheter, which I'm just trying to advance inside.
Okay.
Okay, we got it inside, very deep.
Wires out.
Now, what we are going to do is we are deep inside the ventricle, which is what I want to do, where the gradient should be in the cavity. And now I'm just going to take a pressure reading. So let's put
Where do you want to put
this one on
this?
this. Yeah, and I want that one. I just want a direct pressure tracing. Actually, give this to the LV. Give me. Okay, and both are zeroed correctly.
Yes.
Okay. All right. Can you give me and give me a aspiration syringe? So the double lumen Langston catheter is not always the best side port, but let's see what happens. It sometimes dampens the side. So I'm giving that flush.
Hey, who's
Okay.
outside?
Okay.
We are doing simultaneous pressures on the two channels. Can you get those?
Yeah. So you can see the gradient has decreased significantly. So call the red LV and call the aorta, PA called aorta. So now the P gradient is 30. So we started with a gradient of 100.
Yeah, just name them again.
So there is still a post-ectopic Brockenberger phenomena, which will take some time to, yeah. Okay, good.
I don't know whether this line is flushed properly.
No, it's the side port is very difficult to pop. Okay, so the overall gradient has.
Oh, no, there were bubbles here.
Okay,
1 second.
we're just going to flush it again. But when we started, Vishwa, the blood pressure was 230 LV systolic. Look at it now, because this is now the lot of ectopics. Okay, sorry. Lot of ectopics. Okay, so now it's
That's a stable rhythm.
okay. So that's a stable rhythm with some ectopics. So once in a while you get an LV. Now I'm going to pull back gradually and show that in the LVOT there's no gradient. See that? That's all aortic gradient. And then if you pull back further, so this you
Can't
didn't.
record anything? Okay, this is a good.
Can you? Yeah, we can't get in a post ectopic properly. There's a lot of ectopics. Okay, just record that.
Okay, that's your non-ectopic gradient.
With some ectopics, which is fine. Record that. Just record it. Man, just. You done or not? Okay, good. Now ready for pullback? Yeah, this is, you see that? This is LVOT and LV, there's no gradient because it's a subannular. And then you go back right side of the aorta, it's all okay. So now we're done over here. Gonna get a wire. And we're going to keep the pacemaker wire inside the neck. And we're going to put a TR band. And so I like to summarize this case. This is a patient with hypertrophic obstructive cardiomyopathy, severe SAM, severe mitral regurgitation, as well as a peak gradient of over 100 and post-ectopic 250 gradient. We did alcohol ablation of the first and second septal perforators. We have reduced the gradient by 50%, and we can show by echocardiography. Roxana, can you show the images, last images? Can you show them? This is I wanted to confirm that we have actually ablated the basal part of the septum. And guys in the camera, just I wanted to show you that since that was the question asked. Can you just show the septum? Yes. Can you show echo last? Okay, yeah. Yeah, we're going to show the echo images last now. And we want to show you the bright spot. If you see the bright septal spot, which means that is exactly where we wanted to do. And what will happen is that because there's no clear-cut right bundle branch block now, the gradient is not reducing that much. But then what will happen is over the next few 6 months, that will get scarred. And once there's scarring of the basal septum, the gradient will drop. The gradient just, yes.
I think the volume of the myocardium
Yes.
right now has not reduced.
Yeah, just contracted. That's all it is. Yes.
And with time, the volume.
Yeah, yes, yeah, absolutely.
In that.
Yeah, but I'm very happy that we did the right spot because this is the advantage of echocardiography to tell you that you've actually done the right septal perforator.
That hyperecho
Yeah, and I.
is what is going to be ablated.
Yeah.
Very good case, Saibal.
Yeah. Thank you, Vishwa. This was really. So with that, I want to thank you, everybody. And I wanted to demonstrate a unique case, and I want to thank all the staff to have stayed so late and helped us out. And Steve, thank you very much for being there again for all of us. Thank you. Even though.